transfer. And before I engage in this, you know my bias is toward fat transfer, but there's so many ways to skin a cat. You've seen tremendous variability in techniques, but ultimately great results from really people that are very experienced with great hands. So I'm not trying to be dogmatic. I'm just trying to express what has worked for me and some of the rationale behind what I do. Going back to the slide with Sharon Stone, you see that to me, a large component of that aging really is a volumetric loss. And that volumetric loss is principally soft tissue. There's more bone exposed. So my argument that you'll hear here is twofold. Number one is that we really have more soft tissue than hard tissue loss, and it's everywhere. So you need to do a little bit everywhere to get the results. So that analogy of communicating with patients with a pitcher of water, the idea is that we're going to refill the soft tissue component, and it's a great way to communicate when you understand that you don't want to put too much in, just the right amount in all the right areas to get the result you're looking for. And remember, so at 20 years of age, sometimes it's just too full. And oftentimes the ideal for women may be early 30s. For men, it could be even later than that. So I want you to think about this is that our face is primarily soft tissue, overlying hard tissue. As we get older, my argument is that we lose more soft tissue than we do hard tissue. The days when we had bad dental hygiene and we completely lost bone in the midface, that we don't have as much hard tissue loss. So if this is the paradigm that we're looking at, where you're getting a greater degree of soft tissue loss compared to hard tissue loss, if you put an implant in a single zone, you're going to create actually more exposure. You're going to exacerbate that bone exposure that you would see otherwise. Let's take the opposite paradigm. If you're going to put fat in, you're going to make it more youthful because that distance is going to be more similar to where it was at youth. And if you look at this, it's bone not just in the cheek, it's not just in the brow, it's not just in the temples, not just in the chin, it's not just in the buccal area, it's everywhere. And that's really where I want you to remember that talk I gave a couple days ago about understanding the face and all its minute subcomponents. So we're not just putting fat in one area, we're really distributing it in a beautiful way. And if we do that, and we don't just stick it in one area, but we really artistically shape the face, then what we're doing is taking those transition points and minimizing it with fat grafting, and you're going to exacerbate it potentially with an implant, unless you're doing multiple implants all over the face. A nasolabial groove implant, a brow implant, a temple implant, a mid-cheek implant, an outer cheek implant, a central buccal cheek implant, and you can't put an anterior chin implant because there's a nerve there. But these are the things that I want to articulate, that if you really start to finesse the face using implants in a subtle way, with fat grafting in a subtle way, or fillers in a subtle way, you're going to create fewer transition zones and create better highlight reflexes. So going back there, if you just put a chin implant and a cheek implant, which is has been the standard of volumization in the past, and it's just a bony implant, and you're putting it in isolated zones, you potentially can exacerbate the transitions, potentially exacerbate the bony exposure, rather than softening and mitigating those transition zones. So if you look at this lady here, I think it's going to be hard-pressed for anyone to try to create the same or similar results with a single implant, unless you're putting in 5 to 6 implants to try to recreate this. At least that's my argument, and you can't have the finesse work with this. Same thing here. I think it's harder to achieve that coverage when you're just using 1 or 2 implants. Same thing here. This obviously with botulinum toxin as well. Is fat a perfect treatment paradigm? No, it's really not. And what I like to have you understand is that fat can be dangerous. And we always have this idea that fat is just perfect, but if you don't understand the limitations, then we can do things that are potentially long-term dangerous. It is a permanent injectable, and it is not bioinert. You can't treat it like a hyaluronic acid. It is a bioactive substance that behaves like the donor capacity. In other words, like the donor fat. It can be more sensitive to weight gain, and that's one of the big things. So I see a lot of people inject fat in an 18-year-old thinking it's not a big deal. It can be a big deal by the time she hits 40. And I was remember lecturing in Columbia, the country, back in 2007, and the gentleman that was right after me said, "Sam, I wish I had heard this talk, because I filled a whole mandible with like 20 cc's of fat in a 17-year-old to try to recreate it. and 3 years later, it started to bulge with some weight changes. So you got to be highly, highly careful. So the younger you are, the more weight fluctuations, the more risk you have with fat. So this is not a glorified lecture saying fat graft the world. It's about understanding discretion, it's understanding restraint, it's understanding artistry to get those results. But I like this sort of paradigm of like replaces like. If someone's got a weak chin, don't stick it with fat. Put a chin implant in. Although I would say that one of our colleagues in the facial plastic surgery world said that the cheek implant is a flawed procedure. I sort of like that because there's a good percentage of infections in that when you put that into that mid-zone. And I think you can't truly capture the beauty when you start to subdivide the cheek into literally about 5 to 6 regions, which I do when I conceptualize it, as you heard yesterday morning. This gentleman had a chin implant, and he had some lipocontouring of the chin. I don't think I can get this result by sticking fat in there. You're not going to get the bony augmentation that he needs. Conversely, this lady has large cheek implants, which I removed and then I blended in. Now, clearly you could say, hey, Sam, look, I do cheek implants and I don't get these kind of ridiculous results. Granted, yes, that's great. I think it's fantastic that you don't. This is just an argument on one side. That's all it is. I think the older you are, to me, it just makes so much more sense to do fat grafting, given the caveat if that weight is stable or they're in the process of losing. The younger you are, you can cover the implant. You've got soft tissue envelope, and if it gets worst case scenario, take the thing out when they get older. If they're dealing with someone who is, so the idea is that if soft tissue is lost, okay, if soft tissue is lost, replace it. Like replaces like, and if you've got a weak bone structure, replace it with some kind of alloplastic augmentation. And this one, I can't underscore this enough. I don't know how many of the presenters have talked about the limitations, but this is, I've had 2 or 3 patients, as I mentioned a couple days ago, that just look terrible. They gain 30 or 40 pounds, and they don't look good with fat. I've seen them lose the weight, and they look tremendous. But that's something you really, really need to underscore in all your consent forms and as you articulate this procedure to each patient. My book, and if you need to reach me, there's my email. Thank you very much.